Good morning, good afternoon, everyone. My name is Lauren Nobby, and welcome to the Cano ACAO webinar, Preserving Hope, the Role of Oncology Nurses in Supporting Oncofertility Care for People with Cancer, presented by April Wales. April Wales is an oncology nurse by background, working for Cancer Care Alberta as a senior change management consultant, especially focused on projects within supportive care services and patient experience that are aimed at improving patient care and experience throughout the cancer continuum. We're excited to have you for this important discussion. April will present for 40 to 45 minutes, followed by a Q&A session. During the presentation, all lines will be muted, but you can submit your questions anytime using the Zoom question box or chat box. If you have a question throughout the presentation, you can also place it in the chat box. After the presentation, we'll address submitted questions. If you'd like to ask yours live, simply raise your hand and we'll unmute you for the Q&A. Note for attendees, live translation is available through Wordly. To access translation on your Zoom webinar panel, click the apps icon. Select Wordly from the list of available apps. Choose your preferred language from the menu. You can view your translations captions directly in the Zoom or click the icon with the arrow in the box. At this time, I'd like to present to today's presenter, April Wales. April, you may begin.
Thanks so much, Lauren. Hi, everyone. I see there are some people kind of joining as I go, but nice to be here today and excited to be talking to you about a topic that I'm pretty passionate about overall. So thank you for being here, and thanks, Lauren, again for that introduction. I wanted to start off with a land acknowledgement, more specifically to where I am coming to you from, which is Calgary, Alberta. And so I am on the ancestral and current lands of the Blackfoot, the Tsuut'ina, Stoney Nakoda, and Métis peoples who have cared for these lands for generations. I want to acknowledge and recognize the First Nations, Odipimisawak Métis government, Southern districts, and the many urban First Nations, Métis, and Inuit whose cancer care may be entrusted to those of us who have the honor of working in the new Arthur J.E. Childs Comprehensive Cancer Center here in Calgary. More personally, from a land acknowledgement perspective, the picture I'm sharing here is my home away from home, which is where my husband and I spend a lot of our time in the nicer months. And we have the opportunity to be visitors and explore the land, typically mostly in southern Alberta, in an area that's now known as Livingston, and it's around the Oldman and Livingston rivers. I have always had a deep tie to camping and exploring and being outside. And so what resonates for me with Indigenous culture is really that deep and meaningful connection that Indigenous peoples hold with the land. And I feel honored every time I'm able to drive away from the city and enter the mountains and visit those lands and witness their beauty. I make this acknowledgement as an act of reconciliation and gratitude to those whose territory on which I live, and I acknowledge and continue to learn from the harms and the mistakes of the past. I forgot I have one more picture to show, and that's of our very cute dog, because I can't not share her. She is our perpetual camping companion, and so is always with us when we are on our adventures and seeing some pretty amazing places across the country and even further south, actually. So for today's webinar, here's the objectives. I won't kind of read them out to you per se, but what I'm really hoping you'll have by the end of this is a really good understanding of how important oncofertility is and early integration of oncofertility conversations for people with cancer, a good understanding of what's out there for clinical practice recommendations, what the care available to patients across Canada is, and some basic information about some funding supports that are available. I've tried to focus on giving a general landscape, but there may be some more specific things within your jurisdictions that you are aware of, and I would really encourage you to share those in the chat. I'm a pretty informal presenter, so I will be watching the chat as well, and I'll do my best to kind of address questions as they pop up in there. And really also want to spend some time talking about how, as oncology nurses, we can integrate oncofertility into our practice, how we might introduce it to patients, especially as they are just coming into the cancer system with a new diagnosis, and how those conversations may evolve over the cancer continuum. Thanks, Brenda. She is a pretty cute dog, I have to say. So, starting off, what is oncofertility? I think most of us are fairly familiar. It feels like a term that's out there quite a bit now. But just to level set, in case no one is really sure or someone's not really sure about it, oncofertility is really a cross disciplinary collaboration, and it brings together oncology and reproductive medicine with the aim of addressing fertility care needs for cancer patients. And fertility care itself encompasses quite a bit. It certainly covers fertility preservation. So that's one of those key points for those newly diagnosed individuals in terms of preserving their fertility and their hope of having biological children after their cancer treatment. But it also moves along the continuum into, say, fertility treatments down the road for either someone who has completed fertility preservation, or maybe they didn't or weren't able to do so, but they do want to pursue fertility treatments like in vitro fertilization. And ultimately, why do we even need oncofertility? So, as a discipline in the care that's encompassed within oncofertility care, it's a really important aspect of oncology, as a cancer diagnosis or its treatment can render a person infertile. So, for people with testes, this can mean that treatment can affect spermatogenesis or the production of reproductive hormones. And those are obviously pretty essential when we come to that prepubertal development and sexual function. And for people with ovaries, we see that cancer treatment can accelerate follicle and oocyte depletion, which can lead to premature menopause. So it has some pretty significant impacts on a patient, and that means impacts in the moment. So especially for people with ovaries and that thrust into premature menopause, but those impacts can carry on for quite a long time when we think about cancer-related infertility. Through my work in Cancer Care Alberta, specifically around a project around oncofertility flags, so kind of flags that pop up and tell our providers and our care teams, hey, this is a patient of reproductive potential. We need to talk about this. We had the opportunity to work with one of the fertility specialists here in Calgary, and her name is Dr. Fong. She created a digital story for us that is quite powerful. And I wanted to share it with you guys today because I think it gives a really good perspective and brings up some really important points when we're thinking about how we have these conversations and what this actually means to our patients.
Doctor, I have decided to keep my baby. Her words still echo in my mind over 10 years later. She was an educated and informed woman, and she had made her choice. In that moment, all of my biases and assumptions had to change. We would have to think differently about her chemotherapy plan while she continued with her pregnancy. It was no longer just about treating cancer, but truly caring for the whole person. The field of oncofertility is relatively new, and I still recall the early years. We knew that early referral to a fertility specialist was essential for a patient to have the time to explore options and make a truly informed choice on which path to take. So I started connecting with oncology surgeons and medical oncologists, offering to do educational sessions and explaining how I could be of assistance. Quickly, I realized that educating nurses, social workers, and other allied health professionals was critically important too. They were all valuable advocates for their patients. They just needed to know who to call. As the work progressed, we gained a deeper understanding of the barriers that still existed. Finances were always a challenge, so we approached pharmaceutical partners for access to compassionate medications and worked with charitable organizations to help patients with their costs. but there were also hidden barriers. Through my research regarding referral decisions, we realized that there were unknown biases at play. People that were older or already had children were less likely to be referred. And so we began incorporating this knowledge into our education programs. We were initially very focused on the logistical side of things, but I will never forget when I realized that oncofertility was about more than just having biological children. I was sitting with one woman in her late 30s who had just been diagnosed with breast cancer. I asked her, "Who do you have for support?" "No one. The closest person in my life is my mother, and she is in hospice with cancer. I can't share this with her." She went on to describe how her life had been spiraling out of control, and for her, freezing her own eggs represented the future and was a reminder that there could be life after cancer. In that moment, I realized that all my consult conversations were always about more than fertility. They were about hope. I've witnessed a change in our mindset from treat your cancer first to a willingness to accommodate other desires and needs of patients and their families. I've also seen significant improvements in the time frame to complete fertility preservation treatment from 6 to 2 weeks. But there has also been a lot of changes in my own understanding as well, starting with the woman who decided to keep her baby. A year after that initial meeting, she made an appointment just to introduce her baby to me. She wanted to thank me for creating a safe and supportive space, allowing her to make her own choice freely. Oncofertility is about making room for these discussions, no matter what the outcome may be.
So I always find Dr. Shu's video so powerful. And even in presenting this or working on these slides, in the work that we were doing in Cancer Care Alberta, even last year, we just put our kind of project into place in our electronic health record. And even presenting this, I had the opportunity to present in Grand Rounds in Calgary and in Edmonton and shared this digital story. And each time I listen to it, that concept of preserving hope is something that really sticks out for me. So hence the title of this presentation. Oh, Julie, I am right there with you. I realized I probably should have turned off my camera because I did have a couple tears forming there. And I'm going to apologize because there's another video coming and it will definitely tug on the heartstrings. So please make sure you have some tissues handy. So I want to talk a little bit about the importance of oncofertility care. And I mean, obviously, what Dr. Fong spoke to in terms of that hope, that's such a vital component for patients. And it's so important for us to preserve, but there's a whole lot more that comes along with this. So really the big why, we are seeing a rising cancer incidence in our adolescents and young adults or AYAs, and those typically make up the bulk of the patients who are diagnosed in their reproductive ages. And what we're seeing is for 2025, there were actually just about 10,000 individuals across Canada that were expected to have been diagnosed with cancer in those age ranges of 15 to 39 for AYAs. And what we see overall is that the prevalence of cancer is rising. More people are living with and beyond a cancer diagnosis than ever before. And that trend alone has really started to heighten that need to look at survivorship care as a core component of how we support patients across that cancer continuum. People are not seeing that shortened or the same shortened life expectancy that we used to see. They're living well beyond their cancer diagnosis. And ultimately, oncofertility care needs to be integrated in survivorship care. And that includes talking about those fertility and reproductive risks early on before a patient starts treatment, reviewing fertility preservation options, supporting people who want to proceed with fertility preservation prior to starting treatment. And that also includes assessing their informational needs related to their fertility and reproductive health throughout the cancer continuum. So, talking about the impacts of sexual function for people with testes, talking about the impacts of menopause and early menopause for our patients. One of my best friends was diagnosed with colorectal cancer at the age of 42. Maybe perimenopausal, but not menopausal quite yet. She has 2 kids. No one actually even introduced the concept of menopause to her or the concept of fertility impacts to her until she was well through chemo and starting her radiation. And so it's really important that this isn't just necessarily limited. We're going to talk a lot about fertility and oncofertility, but it is also a reproductive health component. And so while it's important to talk about that fertility impact, it's also about that reproductive impact and how that impacts a person. So really supporting those individuals as well when we're past treatment in terms of pursuing fertility treatments if they want to do so. So there's really a huge amount that kind of comes into play with oncofertility care, and being able to provide survivorship care really includes upfront talking about those fertility and reproductive risks. One of the biggest things that hit me when I looked at this statistic is, we know survival rates are increasing, we know prevalence is increasing, but we're seeing this world now where our AYA patients are surviving 50 to 60 years beyond their cancer diagnosis. We have the ability to understand these late and long-term effects that people live with post-cancer. And so cancer treatment and support really can't stop right when we're sort of done treatment or like the prescribed follow-up. There's a lot of impacts that follow an individual through their life, especially when we think about those individuals diagnosed with cancer in their AYA years. So a little bit of a warning here. This is the video that will certainly tug on your heartstrings. I will be right beside you there, so I'll probably turn my video off for a little bit. And I do also just want to call out, if you are someone who has faced infertility in your life or reproductive challenges in any way, this might be especially emotional. I'm one of those people, so I do have infertility, thankfully not related to cancer in any way, but it can be a little more extra emotional. So I just want to call that out before I start the video. So this is a story we had the pleasure of making with one of our patient and family advisors here in Alberta, and it's really poignant in sharing that patient perspective and impact in terms of thinking about oncofertility when a person is newly diagnosed.
As I looked at the screen, my heart skipped a beat. It was a message from my family doctor at 5:27 p.m. on a Wednesday. What is Ewing sarcoma? What is the prognosis? We began to look for answers, and one word stood out: aggressive. In just a few short minutes, a relaxing evening with my sister-in-law turned into a night filled with shock, anger, fear, and a deep sadness. For 6 weeks, I had been trying to figure out what was going on. I went to the doctor and the hospital emergency rooms countless times. Each time, I received a new prescription because it was probably some type of infection. I was young and I was healthy, and it couldn't be something serious. Finally, a new doctor recommended I go for an ultrasound, and then another ultrasound and a CT scan. Then it was recommended that I get an MRI as soon as possible. It was booked for 3 months later, despite the doctor's writing urgent. So I paid $1,000 for a scan I urgently needed, and that day I received the news that I had likely some form of aggressive malignant sarcoma. And then I waited. Waiting to find out the results of my biopsy. Waiting to see if I could survive this. Waiting to see if I can get married, have a family, continue building a career. 3 weeks of waiting. When I finally met my oncologist and she outlined my treatment protocol for the next year, I began to realize that my life would no longer be in my hands, but in the care of modern medicine and the knowledge of healthcare professionals. I was given a booklet of the side effects I could get from my 5 different chemotherapy drugs, and as I skimmed the document, another word jumped off the page: infertility. The fertility clinic in Edmonton was closed, so a few days later, Mitch and I were driving to Calgary to learn about the process of egg preservation. It would take 3 weeks of hormone injections, and I would have to pay out of pocket. And it didn't include the storage or transfer of the eggs later. We had just built a house. I was in my 2nd year of teaching. It was too much money, but we would find a way. During the drive home, I felt all the anger and fear all over again. I had spent 3 weeks of waiting to see my oncologist for the first time, even though it was almost certain I had cancer. Later that evening, the nightmare was complete. I received a call from my oncologist who had spoken with the fertility specialist. My tumor had grown exponentially, and if I delayed chemotherapy, my staging would most definitely change. Mitch and I had one night to decide if I should delay chemotherapy for fertility preservation or start chemotherapy but lose the chance of ever having a child naturally. One night, when I could have had 3 weeks. We didn't choose fertility preservation, but we still did the best we could to give myself a chance to have children. After surgery and months of chemotherapy, I traveled to Boston for proton radiation to potentially keep my ovaries from being damaged and protect my other organs. But when the dust settled, I was in menopause, and I had to start hormone replacements. I was told I had little to no chance of being able to have children. The past 3 years have been hard as I watched my friends' pregnancy announcements, feeling both intense happiness and grief. And a few months ago, I scheduled another appointment at the fertility clinic to begin the egg donation process. We wanted to become parents, even if it was someone else's DNA. 3 days before the appointment, something in my body seemed different. So I did a pregnancy test, and then I did 3 more. And in 2 months, I will have my first child. I am incredibly thankful for the amazing nurses and doctors that saved my life. If it wasn't for them, I would not be here today and able to live life to the fullest. And I am very grateful that miracles do happen.
So hopefully you made it through without too many tears. The story that always brings me a lot of hope, but it's such an important view into a patient's perspective, especially as they're coming into the cancer system, receiving a new diagnosis, and then also grappling with the impact of cancer-related infertility, depending on their diagnosis or their treatment. So perhaps not surprisingly, cancer-related infertility has a pretty significant psychosocial impact on individuals. And in fact, for AYA cancer survivors, it has been indicated to be one of the most distressing long-term effects of a cancer diagnosis. So those impacts on the psychosocial realm can really vary and they can fluctuate. Often it comes with depression, anxiety, grief, low self-esteem, poor sexual or relationship well-being, and challenges overall to gender identity. And that impact is very dynamic. It changes, it moves, it may be different at diagnosis, it may be different even 3 cycles into treatment, and different still when an individual moves into follow-up or into survivorship care. As each of these kind of milestones come for an individual, there are different components and different emotions that they may be dealing with. And they may also be dealing with some different emotional triggers in that realm from their personal life. So it's so important to understand how much it can evolve and change across that cancer continuum. And that's really where it's so important to not only set up that first conversation, have that discussion around oncofertility at cancer diagnosis, but to check in and to ask how someone's feeling, to support with different emotional supports. Even just some validation and acknowledgement can sometimes go a very long way. But ultimately, what I want and hope that you can take away from this is how much the conversations we have about fertility and reproductive risk, however negative that may feel, there is also a component of this about hope. Fertility and having children beyond a cancer diagnosis can really represent such a light at the end of the tunnel for our patients, and it's such an important component. And I think what Dr. Fong referred to in her video when she talked about just having the space, understanding that the outcomes might not be exactly what we think. Not all patients will move through fertility preservation, and I'm sure we all can kind of talk about why, with respect to finances and the challenges and barriers that exist for it. But even having the conversation can open that space for a patient and let them look into their future beyond a cancer diagnosis. So we have a lot of really great clinical practice recommendations that are out there. In addition, we have our position statement from CANO and AFON around the importance of fertility preservation in people with cancer. As early as 2006, the first guideline from the American Society of Clinical Oncology was released, addressing fertility preservation in people with cancer. And ASCO tends to be the one that gets relied on the most. It's certainly the one that we use most often here in Cancer Care Alberta. So that original guideline published in 2006 has been updated subsequently. So there have been updates in 2013, 2018, and actually most recently last year. And some of these updates are related to more understanding of what the impact of cancer-related infertility is. And some of them are related to some of the advances when it comes to fertility preservation options for patients. We do also see in 2014 that the Canadian Fertility and Andrology Society released a similar position statement, and most of these guidelines, including that European Society of Medical Oncology, the guidelines really all speak to the same thing. So I'm going to kind of mention some key components from the ASCO guidelines themselves. So first of all, as clinicians caring for adult and pediatric patients, and I do want to just say my experience lies primarily in the adult ambulatory care space, so I can't speak to a ton of nuance around pediatric conversations, but I have learned a little bit in the last couple of years. So as clinicians caring for adult and pediatric patients, we should be addressing the possibility of infertility as early as possible before treatment starts to preserve the full range of options. As nurses, that can be a tricky space. It is certainly up to our physician counterparts to discuss, the physical impacts of a cancer diagnosis itself and the treatment risks and benefits. And within that, discussing fertility and reproductive risks, especially as they relate to treatment, are certainly a physician responsibility. But I think it's important to note that as nurses, we can absolutely introduce that topic, and I'll talk a little bit more about that. We need to think about referring patients who express an interest in fertility preservation and those who are uncertain to reproductive specialists. So I want you to hold on to that one because that one's going to be an important point. And really, we need to initiate the discussion regarding infertility with the knowledge that even just talking about it can ultimately reduce the distress and improve quality of life for patients, even if they don't move forward with fertility preservation. So a little bit about what we have available across Canada. The Canadian Partnership Against Cancer has actually done quite a bit of work in this space. They've done a lot of work around understanding current state. And most recently in 2022, they published the business case for oncofertility screening in the cancer system. And that included some really important recommendations for cancer jurisdictions around identifying patients who would most benefit from an oncofertility conversation. And that's where our specific project within Cancer Care Alberta came from. But part of the document that they released also identified kind of the current state of fertility preservation services across Canada. So this is a map that's present in that document, and I will share my slides after. There's a reference page with hyperlinks to everything that's kind of present in here, including those digital stories. So I do just want to call out that if you are wanting to use those digital stories in any way, shape, or form to bring back to your jurisdictions or your teams or to start conversations amongst your teams, they are publicly available on YouTube. So this is kind of an environmental scan in terms of each province and territory. What do they have for clinics? What's available for fertility preservation coverage, and even some additional information depending on the province. So there is a bit of variability across the country as far as access. We can see none of our territories have a fertility clinic. And so those individuals are often traveling incredibly long distances, not only sometimes to receive their cancer treatment or to see an oncologist, but to even try and potentially move forward with fertility preservation or future fertility treatments. So geographically, we certainly have, the consistent issue with respect to access to clinics. Funding is a really big barrier for patients, so we can see across some of these provinces. Now, I will call out, I believe in the last year and a half, we've seen a few provinces move forward. And currently Alberta, unfortunately, is our only province that does not offer some form of publicly funded support, whether that comes through a tax credit or whether it comes through kind of upfront cost reduction or coverage through a publicly funded program. And so there is some advancements, and that is improving, which is really encouraging. But there is still components of access that can be incredibly challenging for patients. As you likely know, or hopefully know, fertility clinics do sit outside of our publicly funded healthcare system, and so patients are needing to pay out of pocket. However, a fertility preservation consult, an initial conversation with a reproductive or fertility specialist at any of the clinics across Canada is covered by provincial health insurance. So I want you to keep that in mind when we think about referring anyone and everyone for a fertility consult. That might seem like, well, why would we do that if they can't afford it or they're not going to move forward? Sometimes just having that conversation and understanding the lay of the land is the best way to help patients move through some of that process, giving them the opportunity to get that information and make the decision for themselves. But also just not making assumptions about who might want to or who wants to hear about it. In terms of the different procedures that are available, more specific to fertility preservation, these are the common options that we see across Canada. So for people with testes, most common is sperm cryopreservation or sperm banking. That can be completed usually within, sometimes the exact same day as an oncology consult. It's a fairly quick and easy procedure, which seems kind of unfair when you consider the or what people with ovaries have to move through. There is some experimental work happening in the area of testicular tissue cryopreservation. So I don't know a ton about the current landscape with that, but I do know there has been some procedures here experimentally in Calgary. And I think I want to say a few in Ontario and maybe BC. So that is currently experimental. It's not routinely offered. And so if that's something that a patient wanted to pursue, they would need to likely travel to one of the centers that is offering it as an experimental option. For people with ovaries, the mainstays are either egg banking or embryo banking. And so that can really come into play as far as, does a patient have a long-term partner that they are wanting to do embryo cryopreservation? Do they need a sperm donor to come into play at all? I will say there used to be quite a bit of a delay when it comes to starting treatment and proceeding either with egg or embryo cryopreservation, and that's been very much improved. So where we used to have to wait and sync it with cycles and all that kind of thing, there's been advancements in that space, and now it will typically take about 2 weeks. So it doesn't need to be synced with a patient's cycle. So that's a great advancement. And there is literature out there showing that waiting to start treatment for 2 weeks in most cases, obviously, there are some very urgent and emergent situations where a patient needs to move forward with treatment. But for the most part, patients can wait. And I want to kind of plant that seed for you. I'll talk a little bit about advocacy when it comes to being a nurse in this space and talking with patients. And I think that's a really important component, is advocating for patients in order to move through prior preservation if that's what they're wishing. Another option that actually came off and isn't so experimental anymore is ovarian tissue cryopreservation. So really excitingly, they've seen some really great results with that. And so it is another option for people with ovaries. There is the option for people with ovaries to look at ovarian suppression. So sometimes that tissue cryopreservation or egg or embryo cryopreservation just isn't an option. There is the potential of using suppression with a GnRH agonist medication. However, it's not recommended to be an individual's like sole plan as far as preserving fertility. There's conflicting evidence. It's kind of a little up in the air, but it is offered to some people. And for those patients who are prepubertal, most of their options would rely on tissue cryopreservation. So that's really where I think some of the work in testicular tissue cryopreservation is happening. But for patients with testes, it can be possible to do surgical retrieval of sperm. So that is a potential option for a patient who is prepubertal and isn't able to ejaculate, or for an individual who's like a little bit older and not able to ejaculate. As far as provincial funding goes, as I mentioned, most of our provinces now offer something. So BC, Saskatchewan, and Yukon introduced programming in the past year in 2025. And in Alberta, we're the only province that doesn't have some form of funding support. But there are advocacy activities happening. And I want to also speak to, for anyone who's been at Cano in the last, I think, couple of years now, we've had the Canadian Cancer Society coming and talking about their advocacy work in this space as well. So I know provincially, with each provincial government as well as federally, the Canadian Cancer Society is really active in advocating. I think really looking towards Australia as that kind of model. Right now, Australia actually includes fertility preservation as part of cancer treatment. So patients don't need to pay out of pocket, and it's just kind of integrated in like the referral intake process. There are some kind of limitations on it around, cost savings and making sure it doesn't go too wild. But for people who want to proceed with it, it is included in cancer care. And so I believe the Canadian Cancer Society is really trying to advocate for that type of approach as well. In Alberta, we also have a Fertility Alberta organization that is advocating quite a bit, not specific to cancer patients per se, but just in general for a publicly funded program in the province. I think, though Alberta might be dragging its heels a little bit, I suspect they're going to have to do something at some point here, because really being the only one looks pretty bad overall. And then I just want to call out that coverage for fertility preservation specifically, especially in those provinces where there are publicly funded programs, varies. So for example, in BC, if memory serves, fertility preservation is not included, but it may be a potential to include some of the medications. The procedure it may not be covered. So I included all of the hyperlinks here that give you more information about each of those programs, so you can look into that more specifically. And I want to just also call out that in some provinces, for example, Manitoba, and I think Saskatchewan has a tax credit as well, and maybe one of the Maritimes provinces that's escaping me at the moment. Those tax credits are fantastic, but it does still require people to pay up front. So even though there is some relief down the road, it can still be a barrier in terms of pursuing fertility preservation. As far as some funding supports that are available across Canada, and again, in your jurisdiction, there might be something more specific. I know within Cancer Care Alberta, we have our Alberta Cancer Foundation, and so there is some potential there to access some funding for patients. But I wanted to just give a good idea of what's out there Canadian-wise. So the most popular and what's most visible, I think, for many people is the Power of Hope program, and that comes through the organization Fertile Future. So Power of Hope is actually a cost reduction program available for cancer patients at participating fertility clinics. So there may be clinics in your jurisdiction, in your province, that participate in Power of Hope, and it offers essentially just about like a 50% discount for patients. So where they might be looking at maybe $9,000 for egg cryopreservation or embryo cryopreservation, they could pay between 4,500 to 5,000. One of the key things to kind of be aware of and pay attention to is medication coverage. So sometimes, especially in some of those publicly funded programs, the procedure itself might be covered, but medications aren't. Medications for fertility preservation, especially when it comes to that egg or embryo cryopreservation, can be fairly costly. There is a federal medical expense tax credit that individuals can use to claim fertility costs. And then the NIHB does offer some fertility medication coverage, but it's generally determined on a case-by-case basis. And so what I would encourage is, if you want to integrate this into your practice, if you sit in a space where, especially if you sit in a space where you're talking with newly diagnosed patients, look at your hospital foundations, look at some of the different cancer organizations in your jurisdiction and see what they offer. I know, for example, in Saskatchewan, there's actually a couple of nurses that I had the privilege of working with. I am from Saskatoon originally, but there's two oncology nurses who actually both faced their own infertility journey. And through that, and through, kind of witnessing patients facing their journey, they've started kind of a grassroots charity to start supporting patients in Saskatchewan to access fertility preservation and storage for eggs, sperm, and oocytes. So it's really exciting to see what's out there. And it's important to know what's out there when you're talking to patients about this. So this is all great. This is all really important information. And I started the presentation with all of this information because I think it's really the first step in terms of how we bring this into our practice. We need to have awareness of the impacts on patients, what it means, what's out there for supports. And what I really want to call out is that we are not, as oncology specialists, as oncology nurses or oncology physicians, no one expects us to be a fertility specialist. I think what we heard quite often from some of our oncologists as we were working through our specific project here in Alberta was that, I don't know, and I don't always have the time to kind of go through all of these details. And when we met with Dr. Fong, she really called that out and said, absolutely, that's not your job. That's my job. So refer your patients. So this is a really key component of how we can integrate this into our nursing practice. So that first step really is educate yourself. Do you know what the fertility preservation and fertility clinic services are in your jurisdiction? What's accessible to your patients? Do you know how to make a referral for your patients? So in Alberta, we had a bit of a hodgepodge for a little while where sometimes our oncologists would page one of the fertility specialists or email or text sometimes. And so we actually worked on creating a streamlined referral process that sits within our electronic health record. First of all, so we were capturing it accurately in the health record and having that visibility to know a referral has been sent, but also to be able to make it easy and simple. All of our other referrals kind of sit within the system. So why wouldn't we try and take advantage of that? And really, too, are you aware of those funding supports? So not just what's available nationally, but what's out there in your specific jurisdiction. I know there's lots of different things to remember and keep track of for patients. And I think this is where you don't have to get into the weeds, but you can say to a patient, this is something that you might be facing related to your treatment. I want you to know that we can connect you with a fertility specialist. They can give you more specific information about what your options are, and I'd encourage you to do that. But I can tell you there is some funding supports available here. We can, talk with the doctor about how that looks in terms of starting treatment. So really having that education at your fingertips and understanding these pieces is that first step of integrating those conversations. As far as some key components to consider, I just want to kind of plant a few things here. And apparently I didn't finish a bullet on this slide, so sorry, guys. For those newly diagnosed individuals, it's really important to know that oncofertility discussions can occur simultaneously with staging and formulation of a treatment plan. Even before that, to be perfectly honest. So one of the things that the fertility clinic stressed for us when we were moving through our project, and even some of our oncologists stressed, was how much they want to see this shift as early as possible before treatment starts. So referring a patient to a fertility specialist as soon as we even have an idea of what treatment might be is such a key component. If a patient has a good sense, and maybe it's tricky to do in the space of not having had a full conversation around diagnosis and prognosis with the patient, but it's so important to give patients the information they need to make a fully informed choice, and being able to see a fertility specialist is one of those things. I also want us to challenge our assumptions here too, and just think about all patients. And all patients might be a very wide net to cast, and AYA patients are certainly those that are more impacted with respect to cancer-related infertility. But I want you to think too about that reproductive impact and how that might look for patients that are a bit outside of that AYA age range. I really want to call out that any oncology care providers can have the conversation. I alluded to this earlier. It's absolutely a physician responsibility to talk about fertility and reproductive risk as they are talking about treatment risks and benefits. It is so important for that component to come from them. There is information out there that can help inform those discussions. If you're working with someone who's maybe not sure, we do actually have a guide here in Alberta that we've created. It is through our Guideline Utilization Resource Unit, and it speaks to the different risks depending on treatment. So it goes through radiation treatment dosages and the impacts for patients with ovaries and with testes, and then it looks at systemic treatments and the risks. So that is something that would be continually updated as evidence is reviewed and as there's more evidence that comes forward. But nursing can provide and start these conversations as well. We can absolutely introduce that there may be a component of reproductive or fertility risk related to a patient's treatment. We can talk about the fact that there are options for preserving fertility. They do have a cost associated with them. We can talk about the fact that a fertility specialist consult is covered and free, so patients can get the information they need. I know in Alberta, oh, excuse me, I have to sneeze. Oh, sorry, guys. In Alberta, I know our fertility specialists will offer virtual consults as well. So if access and geographic access is an issue, that might be an option to explore just so the patient can get the information they need. It can actually be a really important step, even if they don't proceed with fertility preservation, and kind of moving through the coping and healing that comes with dealing with the emotional impacts of that. And again, we're not expected as oncology professionals to be fertility specialists. So you aren't expected to dive into the details, but it's really about presenting it, introducing it, and getting the patient connected to the information and the supports that they need. I want to also call out that oncofertility care is more than just that physical component. It is more than just fertility preservation. It is psychosocial, it's cultural, and it's spiritual. So being able to refer those individuals to psychosocial oncology providers, to be able to seek some social work support when it comes to financial counseling or even financial supports, and looking to spiritual care providers if a patient would prefer that aspect or that approach to kind of more emotional and spiritual supports. And again, I probably can't say this enough, but oncofertility care needs to span across the cancer continuum. So absolutely that early introduction, that early conversation, the connection to supports, referring patients to a fertility clinic, so very important. But that psychological support can be so vital at later time points, especially when patients are transitioning. So if they're moving from, active treatment into a follow-up phase, and they're seeing, life and what might come after, that may bring up more emotional impacts if they weren't able to proceed with fertility preservation. Even if they were, it will bring up fertility issues. And having discussions around fertility preservation options, not fertility preservation, fertility treatment options are, what's the cost associated with in vitro, with getting a sperm donor or an egg donor, and are there funding supports available for those things? So that's incredibly important, and all of these things are within our nursing scope in terms of addressing, discussing, and supporting patients with. I mentioned advocacy before, but I really want you to also think about checking your assumptions and your biases at the door. So fertility and reproductive impacts of cancer should be discussed at minimum with all patients of reproductive potential. So for patients with testes, that age range can be a little bit bigger. For patients with ovaries, it gets trickier. Obviously, as we move into, late 40s, etc., people are automatically a geriatric pregnancy. I think if they're over 35, I want to say. So that conversation may look a little bit different. The odds of being able to carry and have a biological child after fertility preservation or through in vitro might be lower as a person with ovaries gets a little bit older, but it's important to have that conversation with patients and introduce it, especially with patients of ovaries. So with ovaries, sorry, because menopause can be such a fun time, and I say that as someone who's definitely right in there. It's so important to introduce that, even if that's the only piece of the conversation that's had, because it's an older individual. Maybe they've got kids, they're not interested, they have no plans for future children in their family. It's an important impact and a huge life change that we often just thrust people into. So, amongst dealing with everything that comes with a cancer diagnosis, they're also then dealing with such a drastic change in their body. I want to really encourage you, even if a patient is a little bit uncertain or they're totally ambivalent, even if they're pretty adamant that they don't want children, discuss a referral to a fertility specialist. Those consults are free. Getting the information that a patient needs to make an informed choice is free. And so it's such an important component as far as advocating and supporting our patients. And our advocacy in terms of really helping and supporting patients as they move through fertility preservation is so, so important. So I've included a couple of prompts here that can kind of help introduce this. And this first one here on the left, I really want to encourage you to consider. So this is a really nursing appropriate thing. It's a really great way to introduce it without having to, kind of dive into iffy spots where a physician should be talking about fertility and reproductive risk. But it's an important way to introduce it. And sometimes that can also mean introducing it with the patient. And then if you're handing off to the physician, highlighting, I introduced infertility with the patient. I know their treatment regimen can impact their fertility and reproductive health. They really want to talk to you about that and hear more about it. And then really introducing the fact that those fertility specialist consults are covered. The patients can get the information that they need, even if they're not sure about having children. It's just something that is encouraged so that they have what they need to make a decision. And again, sorry, I probably sound like a broken record, but thinking across that cancer continuum. So those impacts of cancer-related infertility and how they stretch from a patient's initial diagnosis through their entire life. Is such an important component. So integrating those oncofertility conversation at transition points, including patients that transition to a palliative approach. So we have had instances here in Alberta where patients who are palliative, who are approaching end of life, who have talked with their significant other, have decided to proceed with fertility preservation. There are some legalities in and around there. I don't know all of the nuances of that, but it is a situation that some people may want to work through and may want to pursue. And so I think it's really important, again, to check those assumptions and biases at the door. You might have someone coming into your clinic who has 4 kids, and they may be devastated to hear that they can't have any more. So not really just not making those assumptions about a person coming into your care and really just providing the information that they need and supporting them. So being holistic in that support, understanding that those emotional impacts can really be far reaching in an individual's life, and really acknowledging those emotions. Sometimes all it takes is a quick acknowledgement to say, this is so difficult, and I'm so sorry you have to deal with this as you're dealing with cancer. Or even speaking to someone as they're transitioning, as we're discharging them from follow-up care, to say, you know what, this might be something that really comes up for you. There are some psychological supports that we could connect you with, or here's a list of information for psychosocial supports if you need it. So in summary, and sorry, I've talked for more than 45 minutes, so not a ton of time for questions, but my email will be on one of my last slides here. So you can certainly reach out if you have any, if we don't have time right here and now. But just in summary, I hope that this has shown you that oncofertility is a really vital component of high quality cancer care, and it spans across the continuum. And really positively impacting oncofertility care and survivorship starts with having those early conversations, referring patients to fertility specialists before they start treatment. It really is so important to bring this forward with all individuals who are of a reproductive age at minimum, in order to make sure they have the information that they need, and really thinking that this isn't just about fertility, but it's those reproductive health impacts, especially when we look at patients with ovaries and the impacts that they can experience related to a very early and quick menopause. The changing landscape of cost associated with fertility preservation and the coverage available is evolving. It's really exciting to see. And hopefully that starts to break down some of those barriers with respect to the financial component that really stand in the way for so many people. I hope you can also see how we, as oncology nurses, are so well positioned to talk about this with our patients, to ensure that they have the information they need to make a choice, to support them as they move through processes, whether they pursue fertility preservation or not, and to advocate for patients. So if a patient really is so so focused on moving through fertility preservation, being able to advocate for that, as it might sometimes go against what we want to say, which is we got to treat your cancer very, very quickly. So always keeping that in mind. As I mentioned, I'll share my slides, and all of the references are linked here. And then all of those hyperlinks in the table with all of those different provincial fertility funding supports and programs, that would be available too. And thank you. Thanks for being here. Thanks for, sharing a few tears with me during those digital stories. I apologize for tugging on the heartstrings this morning / afternoon, wherever you may be. If you have any questions more for me, I am certainly not the expert in this space, but what I hope I've brought forward is just a passion for how we can really positively impact our patients in talking about oncofertility with them. So thanks so much, guys. Thanks, Rosaline. I just saw your message there in the chat, and thank you for joining from Kenya. That's so exciting and amazing. Thanks so much, guys. I appreciate your kind words in the chat there.
So it doesn't look like anyone has any questions. So we'll finish up. Thank you all for joining us today, and a special thank you to April for your insightful presentation. An email will be sent shortly with instructions on how to claim your certificate of completion. If you have any further questions, you can reach out to April directly, or you can send your questions to info@cano-acio.ca, and we'll forward your queries on to April. Thank you all, and have a wonderful day.
Thanks, everyone. Have a great rest of your day.